So this is the last section. This is part three of the respiratory emergencies. We'll talk a little bit mostly about treatment in this section. So it'll be kind of good and assessment. And so it'll be kind of a good exposure to like recap on some of these diseases. And I'll tell you the very high yield, high level, I should say, patho of these diseases so we can recognize them and treat them. So, we need to use so scene size. So I get very annoyed with the book on these where I feel like I say the same thing every chapter, but it's okay. We'll go through it. So we do our scene size up, right? So we need to see if we need to call for additional help or wear additional PPE. We need to make sure we're safe. Remember, our safety's first. So we need to determine the number of patients. We need to know if we need special resources, the nature of illness, blah, 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 blah. Okay. Now we need to recognize life threats and initiate the resuscitation. And the initiation of resuscitation should take priority, right? So signs of life-threatening or surge stress, we do need to know what these are and quickly recognize them. Severe cyanosis, in fact, I'd say any type of cyanosis. Remember, cyanosis is the bluish tint of the skin. It's from deoxygenated hemoglobin. We can see it very clearly when it becomes deoxygenated throughout the body, so it's cyanosis. I will have you know cyanosis tends to appear first around the mouth and the extremities first. That's called acrocyanosis, especially in children. Absent or abnormal breath sounds, audible stridor, right? Stridor is the high-pitched inspiratory sound that we'll hear. It's usually in the upper airways. Dyspnea, which means shortness of breath. Coughing, tachycardia, abnormal breathing, change in respiratory rate or rhythm. Pallor or diaphoresis. What's diaphoresis? It's the medical word for sweating. Use of accessory muscles and tripod positioning. Let's talk about accessory muscles because we haven't talked about this yet. So what are accessory muscles? So we know the typical muscles used for breathing is the diaphragm and to a degree the intercostal muscles, right? Which is like the rib meat, right? The muscle between the ribs. And so that's normal. But when we see accessory muscle usage, you'll see several things, right? So one of my favorites to look for is subcostal retractions, right? Especially up near the up here. So you'll see these muscles up in your neck start working to help you breathe. That's a problem. In infants and even in adults, you'll see right up underneath the rib cage, they'll start retracting there as well. What are retractions? It's when the skin and the muscle kind of retracts inwards when they're breathing. And what's happening is you become so tired using the diaphragm and the regular intercostals that you'll get subcostal retractions and subdiaphragmatic retractions, or what we even call belly breathing, where they're using a lot of their belly, their abdomen, to help them breathe. You see this a lot in children. And in fact, I'll link a video below with what this looks like because you need to recognize this. This is very telling when a 1-year-old child can't raise their hand and be like, "Yo, buddy, I'm feeling short of breath." We have to look at them and assess them and just determine like, "Oh, wow, they're having a hard time breathing because they're retracting." Those are accessory muscles, and we use accessory muscles when the main muscles become tired. Or they're not efficient enough to aid in the breathing, so the body will start using accessory muscles. In the tripod position, remember tripod, hands on the leg, leaning forward, usually they'll be in a sniffing position, okay? So the primary survey, we want to note the general impression of the patient. Remember, our general impression is like our across the room, what do we see? You can pretty much walk in and tell like, oh, wow, this patient's having a hard time breathing just because they're in the tripod position and huffing and puffing air, right? We need to determine if they have an airway. Is it open and clear? If not, we need to fix their airway ASAP. We need to determine if the patient is breathing. If they're not breathing, we breathe for them, okay? And we start CPR. Usually, and we need to provide appropriate oxygen therapy. So whether we decide to do a nasal cannula or a non-rebreather mask, or we decide to do blow-by or something to that. Blow-by is where you just hold it near their face. We do that in children, or whatever it is we decide to do. We might need to provide oxygen therapy. So we assess for shock and bleeding. So we want to check the cap refill in infants and children and adults. Yeah, and adults. Capillary refills definitely the greatest the greatest assessment of perfusion that an EMT and paramedic has. Okay, we can't run blood gases as a paramedic. Not typically. Or we certainly can as an EMT. And so what we can do is just take the nail bed. And remember, we just push on it and let go. And how quickly it goes back to that nice pink color from that white color from us pushing on it, that is a measure of perfusion. And it should be less than 2 seconds. But when we start seeing 4, 5, 6, 7, 8, 9, 10 seconds for it to go back to that normal color, we know that there's lack of perfusion in the capillaries. And so that could mean that they're in shock. And so it's very helpful. So I do challenge you to use capillary refill and the digits. That's the most common. But also check it here, like on the on the arm or something, right? Pretty instant. And check it centrally, right? You could check it on the chest or the abdomen or something like that, or the thighs or something like that. Check it in multiple places because if it's cold, right, that you end up shunting blood to your core anyways. So just don't look at the cap refill and be like, oh well, it's 5 seconds. Well, yeah, it's 32 degrees outside. So that's why it's delayed. So just realize temperature has a big impact on capillary refill because we shunt blood to our core when we're cold for survival. So, we check perfusion by, we could also look at skin color. I don't know if you've ever seen someone who's dying that has like this grayish color to them, very ominous, or they're cyanotic, or they're very pale, or they're red hot because they have infection and fever or whatever. So we use skin, excuse me, a lot to determine perfusion and the temperature and just the general condition of their skin, right? Do they have a good skin turgor? Are they, does their skin look plump? Are their orbits sunken, right? Do they have a rash? We use all these to determine perfusion, okay? So we identify any life threats in your patient. So of course we want to look at airway, breathing, and circulation. If they have a poor initial general impression, that's bad. We need to address whatever's causing this poor general initial impression. We look for altered mental status. Remember, the brain is one of the most perfusion-dependent organs in the body, and we very quickly see when it's not being perfused in the form of altered mental status, then lethargy, then unconsciousness, right? So we look for potential hypoperfusion, also known as shock, right? Chest pain associated with low blood pressure, that's a life-threatening emergency. Severe pain anywhere, So someone's severe pain in their broken femur could cause a respiratory issue because they're hyperventilating due to the pain. Or excessive bleeding, right? Exsanguination, right? So just, these are all I'm flying through these because they're kind of obvious. Now, no, this is I have two stethoscopes. This one's definitely my favorite. This is the one I use every day. So basically, we need to be really good at auscultating breath sounds. And let me start with this. I happen to have a Littmann stethoscope, okay? This is like a $60 stethoscope. Don't be spending crazy money on expensive stethoscopes. If you can't hear it with a disposable stethoscope, you don't need to hear it, right? Hunter Harbold said so. If you can't hear it with a disposable $5 stethoscope, you don't need to hear it. It's just silly when you see like EMTs and paramedics and stuff, even nurses, they'll buy like $300, $400, $500 Littmann cardiology stethoscopes, and it's like, are you listening to heart sounds with that? Probably not. So, are you a cardiologist? Probably not. So, you don't really need a crazy expensive stethoscope, okay? You don't. So, you can buy a cheap stethoscope. It's okay. Now, with that, how do we use a stethoscope? They go into your ears. Your ear canals point this way. So notice that this is bent, right? Because it goes into my ears like this, okay? And I have my AirPods in for the mic, but they go into your ears this way. So you want to bend them into your ear, okay? And the diaphragm, which this is the diaphragm, should be in firm contact with the skin. Now with that, I've seen a lot of EMTs do this. I love it when they do this. This stethoscope changes direction, right? So when you put this in your ear, you need to give a little tappa to make sure you're on the right side. Because if it's twisted to this side, but you're listening with this side, you're not going to hear very well. So make sure you're listening with the right side, which typically for adults, you need to use this. Really, for what you're doing, you don't need a dual-headed stethoscope. That's why my stethoscope is a single-headed stethoscope. Because guess what? I never have that problem of I don't have to tap it because I know it's on this side. So you don't need this dual-headed stethoscope. This is for cardiology. And so basically, you want to make this in direct contact with the skin. There are providers, myself included, that'll end up listening over clothes and stuff. But for an EMT or entry level, or really to do the greatest assessment you can, just put this on the skin. You'll hear very well. You'll be surprised the difference. So put it directly on the skin in firm contact, and listen. Okay. Now, where do we listen becomes important. You want to listen systematically. So don't just be like the madman EMT and be like, oh, I got it, right? It's not like that, right? So you want to listen. I typically will listen up here, and if I'm listening for the lungs, like I'm not going to teach you heart sounds, but if I'm listening to the lungs, which is what we need to know right now, I'll usually listen up in the apex first, right? So here and here. And the reason I do that is because the greatest amount of air flows up in the apexes. Lots of air moving through here because it's closest to the carina. in the trachea. So this is a good place to start to be like, okay, well, this is probably the normal. And I'll have you know, there's fairly limited pathology in the apexes, so this most times should be normal. Okay, not always, but this is going to be a pretty normal place to start. Okay, so now I must point out, it is always left to right or right to left. You don't work your way down the right side and work your way down the left side. You're always comparing the left side to the right side, the left upper to the right upper to the left upper. Okay, so we do this pattern, left to right. We don't go up, down. Okay, so I'll start up here. Okay, I'll ask the patient, take a deep breath in. Okay, right? And then one breath in, one breath out, and then I'll lift it up, one breath in, one breath out, right? And then I'll start listening. And sometimes if there's pathology, I will sit there and hold my stethoscope there for several breaths, okay? So don't think you have to be hot shot and just do one breath like, like a physician. You know, it's okay. You can listen for a long period of time. And you can listen for multiple breaths. And in fact, if there's pathology, you probably should listen for multiple. So, and then we'll work our way down. So we'll listen to the apexes, and then I'll listen right almost near the nipple, where the nipple's supposed to be. I'll listen there, okay? But I'll have you know, right up underneath the ribs, there you're in the guts, okay? So you're not listening to the lungs anymore. So don't go like way down here on someone, right? Whoops. Way down here, it's unnecessary, okay? You want to be like here, here, and really I'd probably start up here, 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 okay? Now, after that, a lot of times I'll listen to the axillary because there's not a lot of meat there, so you can hear the lungs really well, okay? And sometimes we get pneumonias down there in the bases near the axillary, so it's a good place to to listen. So I'll bring my camera down. So I'll listen like here and here, okay? And then you want to listen to the back. Now, I'll have you know, I love it when people, even physicians, listen to the scapula, right? This big triangular shaped bone is called the scapula. You can't hear very well through that. So you don't want to place it directly on the scapula. You want to go here, here, and notice the scapula is here. So you don't want to place your stethoscope on the scapula. I think this is a little bit low. I think that they're outside of the lungs at this point. But, you want to go to the imaginary line of where the diaphragm would be, which on an adult is probably, almost where the ribs are going to end, okay? Because remember, the lungs are completely encapsulated by the ribs. So don't go below the rib line. You're not listening to the lungs anymore. You're listening to the guts. So that is, and you could do this. And, if you have a stethoscope with you, listen to yourself. Go listen to your parents or your friends or whoever you can find. You need to listen to lung sounds on every single patient as an EMT student. I don't care if they called for toe pain or a sore throat. You need to listen to lung sounds on every patient because it's very hard to know what abnormal is unless you know what normal is. I'll give you an example. As a paramedic, I don't really care about heart sounds, but as a physician, I do care about heart sounds. So I have to listen to heart sounds on a lot of patients to pick up like, oh, that's a VSD. They have mitral stenosis. They have aortic stenosis or whatever is going on, right? They have a PDA or whatever I'm trying to diagnose with the heart sounds. I have to listen to a lot of normal heart sounds to pick up quickly and be like, oh, that's abnormal. What's the abnormality? So you should be doing the same with lung sounds. Listen to lung sounds on every single patient. Plus, patients love it. They love it when you listen to their lung and heart sounds. They think that you're some type of physician. They love it. Great customer service. They feel listened to. Listen to lung sounds. You'll see them just light up. It's great. It's so cheap too. It doesn't cost anything. So just listen to their lungs, okay? Now, we got to determine, if the breath sounds are normal or abnormal. And so abnormal breath sounds could be crackles, right? Also known as rels, rhonchi. So where do we get crackles? Heart failure typically. We can also get it with infection. Where do we get rhonchi? Exclusively infection. It's mucus and pus. Where do we get stridor? Upper airway, right? So foreign body airway obstruction or croup, okay? Which is a viral infection in children. Where do we get wheezing? We get this in asthma, COPD, bronchitis, bronchiectasis, okay? Where do we get a pleural fiction rub? We haven't talked about this one yet. What is this? So we have the pleural space, right, which is the space between the lungs and the chest wall, and there's lubricant in there normally, but sometimes that can become inflamed or infected or just lack the pleural fluid, and so you get a friction rub. So you'll literally hear, I've heard this a couple times, rubbing, like it sounds like rubbing your hands together on the chest, okay? You can get snoring sounds. That's really not a lung sound, that's an upper airway sound, but yeah, you can get snoring sounds. So sample history, you could obtain the history from the family or bystanders. In fact, with respiratory distress patients, I tend to limit my questions to them to be pretty close-ended, at least initially until I get them stabilized. Don't have the patient telling you their whole life story when they can't breathe. Oh my God, I worked with this guy who still works at the hospital district. and he's not a bad paramedic, but I lost it on him one day because he just kept asking the patient and the family all these questions that were totally irrelevant. And the guy's like dying. He's like cyanotic. And I eventually just grabbed the cot by myself and start going to the ambulance. He's like, "Where are you going?" I'm like, "Dude, I'm going to put CPAP on this guy. He's dying." Like, don't do that. Don't sit there and start asking a billion trillion questions to the dying patient. Stabilize them. And then you can ask questions or ask bystanders and family after the fact, after you're stabilizing them. Okay. Now, um, limit the questions to the pertinent ones. That's what they're saying, right? Okay, what's going on? Are you hurting? And not only that, if you have a mask on someone like CPAP or a nebulizer or something like that, it's usually head movements. I typically don't ask yes no questions, but in this case, I will like try to ask them yes no questions where they just nod their head, okay? And I'll acknowledge the fact they can't breathe. I'll say, I know you're having a hard time breathing, so for now I'm going to ask you some yes or no questions. You can answer this with your thumb or with your head, okay? And I'll ask my question, okay? So ask about previous medical episodes. Have you ever been hospitalized? Have you ever been intubated? Has this ever happened before? Are you allergic to any medicines? Are you taking any medicines? My favorite thing is just let me see your medicine list or your box of medicines, and I'll just look myself. Pay close attention to the medications the patient is currently taking. Okay, so we can learn a lot, right? If they're taking Montelukast and fluticasone, right? Then you're like, oh, they already have like some type of asthma COPD disorder. Okay, so we know when we can start looking at medications, we can be like, oh, well, you have a history of whatever. Okay. We want to use the OPQRST mnemonic, which is like onset, provocation, quality, radiation, severity, and time. I don't know what the I stands for. That's new. To determine the specific pain information related to problems of breathing. Okay. So chronic respiratory conditions like COPD, right, make it difficult for the patient to breathe deeply enough to clear out the lungs, so they end up with infection. We've talked about this. If a new infection occurs in a patient with COPD, the arterial level of oxygen will fall very rapidly. The same thing happens if they stop breathing. So a patient that's chronically ill, right, whether it's heart or lung pathology or even obesity, they will very quickly desaturate, meaning their hemoglobin will very quickly deplete its oxygen stores because they're already chronically ill. So you see this, with patients like COPD or even fat COPDers. If they quit breathing or they get sick, they very quickly desaturate because they're already chronically ill. Okay, so patients with asthma may have different triggers. Sometimes we try to determine what triggers the attack. It's usually kind of irrelevant in the pre-hospital environment. If we know that they have COPD or asthma, then you treat COPD or asthma. It doesn't matter if the dog caused it or the cat caused it or the pollen caused it. But sometimes it's helpful. You could encourage the patient or family to look for patterns and try to have avoidant, avoid whatever is causing their pathology. So in our secondary assessment, this is where we'll address the chief complaint, perform life performed. We perform this after identifying and treating the life-threatening complaints. We'll look for a change in altered mental status. We'll check the patient's respiratory status, their work of breathing. These are all things that we're going to be looking for. I will say with someone with shortness of breath, of course you can do this with modesty, especially with females, but female patients, it's really good to lift up their shirt and just look at their chest and see how they're breathing. Are they using accessory muscles? Are they using belly breathing? Do they have retractions? There's value in looking at the patient's chest. Okay. Now, this is this is where we start getting vital signs, right? So we assess the circulation. So we look for signs of trauma or retractions in the chest. I've talked to you about what retractions are. That's accessory muscle usage. We obtain the vital signs. And so virtually every patient gets pulse oximetry. You'll see this in the lab. But I just want to point out that pulse oximetry is finicky. And pulse oximetry is dependent on light passing through the capillary beds and being picked up by a receptor on the other side of the finger or earlobe or whatever to pick up the signal. So if the patient has movement, or if there's noise artifact, or there's too much ambient light, since this is light dependent, you'll get artifact, this thing called artifact, which is an inaccurate reading, okay? And so the normal, what's called a pleth wave, should look like this, right? Like this, right? That's normal. And so if I see a pleth wave like that and it reads 86%, it's actually 86%. What is this percentage telling us? It's the percentage of hemoglobin that is bound by oxygen. Okay, so what does 86% mean? It's not how much oxygen, well, it's indirectly how much oxygen in the blood, but it's saying 86% of the hemoglobin is actively bound by oxygen. So it's valuable. That's the value of it. Now, um, so we use SpO2 a lot. Remember, we generally start treating this when it's 94% or less on the National Registry, and really clinically, you're even seeing that as well. Okay. We also use this thing called end-tidal carbon dioxide monitoring. I mean, this is my favorite tool on the entire ambulance. And basically, I'm not going to go into this today. We'll talk about this in lab one day. It's basically measuring the amount of carbon dioxide that you breathe out. So we put a nasal cannula in, and it samples CO2 and it sends it to the monitor, and it'll create this waveform for us to use and make diagnostics on. I'm not going to talk about that today, but just know peak flow meter, you won't use that. We don't use that. Now, and it's silly it's on there. Like, you don't use that in acute, you don't use that in emergencies. Now, the so we reassess, right? And we reassess every 5 minutes on critically ill patients, right? So they can change. These are dynamic patients. So you want to repeat your primary survey and maintain an open and clear airway. Be prepared for suctioning or to use a BVM or to ventilate. Monitor the patient's breathing and reassess their circulation with cap refill. Pulse oximetry, the quality of the radial pulse, right? Confirm your adequacy of your interventions and the patient status. So anytime we make an intervention, we just don't throw a non-breather on a patient and kick up our feet and hope for the best. We have to reassess. Do we need to do more? Is it too much, right? Reassess and record their vital signs as well. Now, we want to keep their oxygen stats above 94%, okay? IV line, this is more of an advanced EMT, so we don't want to talk about that, but provide psychological support. Remember, telling someone slow down your breathing is not going to in fact slow down their breathing. We need to coach them, provide reassurance, be caring, compassionate, and explain to them, hey, I'm here with you. We're going to take really good care of you. Let's work on your breathing for me, okay? Let's really try to focus on opening up our breathing deeply so we can get the nebulized medicine down into your lungs so it can do its job, right? So using common phrases like that and just really trying to be an advocate and being cool with the patient will get you a long way. Don't just tell the patient, watch your breathing, right? That doesn't work, okay? Remove constricting clothing. Do not make the person walk. We want to get the stretcher as close as possible to them and just have them stand up or lift them up and set them on the stretcher, okay? Don't have them walk. And do not lay the patient supine. What's supine? That's laying on your back. What's prone? That's laying on your stomach. We don't ever lay a patient prone. So you're going to provide supplemental oxygen. So you have to titrate oxygen to the desired effect. Remember, we apply oxygen when the saturations are 94% or less. So, if it's 93%, I'm going to put them on a nasal cannula probably. If it's 88%, I'm definitely going to put them on a non-rebreather, okay? That's this thing, okay? So pulse oximetry is a good guide to help us determine where we need to go with oxygenation. But something I want to point out with pulse oximetry is it's about a minute delayed. So you can't just put a non-rebreather on someone and they're go from 88 to 100 or 99% like that. It just doesn't happen. So realize the reading you're getting on the monitor from your pulse oximetry is about a minute ago. And I'm not making that up. It takes minutes for for that reading and the hemoglobin and all and the blood to make its way down to the capillaries for sampling, right, to be picked up. So it's delayed. So realize that it's not instantaneous. It's a common mistake that EMTs make. And so generally it's safe to administer oxygen in a concentration less than 50% to almost anyone. So when you start getting in the non-breather territory, which is this mask I keep pulling out, you're closer to the 100% territory. So what they're saying is if you put like a Venturi mask or a nasal cannula at 4 or 5 liters, it's pretty safe for virtually anyone. You really need to start questioning yourself when you pull out the non-breathers. But this is EMS. We do pull out the non-breathers quite often because a lot of times it's warranted and you need to. And oxygen saturation of 100% should be avoided. There's reasons for this. One is the hypoxic drive nonsense that I was talking about earlier. But the other reason is, this is complicated, but basically when you have a high percent of oxygen dissolved in your blood, it creates something called free radicals, which can cause cancer and it can cause tissue inflammation and damage. This is like extreme cases. I don't think it's important for EMTs and paramedics to really consider that, but apparently your book does. So as a general rule, someone who needs oxygen 94% or less, give them oxygen. So we can administer a bronchodilator. The bronchodilator we use in EMS is called albuterol. Whoops. Spelled like that, albuterol. It is a beta 2 agonist, okay? So we use this in what sound do we use albuterol in? Exclusively. It won't work on other sounds. Wheezing. So albuterol equals, we use this for wheezing, the high-pitched expiratory lower airway sounds, okay? And so it's for bronchospasm because it's a smooth muscle dilator. And what's causing that wheezing is bronchoconstriction. So we give it, it's a beta 2 agonist. It acts on the receptor itself and tells the receptor to do work. Now, the side effects of bronchodilator is anxiety, tremors, tachycardia. That's probably the big ones you need to know. But it will cause bronchodilation, which is really helpful in the cases of asthma or COPD. And again, bronchodilators have very little value in treating conditions like pneumonia, RSV, like viral infections, pulmonary edema, or heart disease. Fact, in fact, bronchodilators can make heart disease worse, okay? Pulmonary edema worse because it increases the heart rate. And when you increase heart rate, you increase myocardial oxygen demand. And so if someone has heart failure, which is causing pulmonary edema, you can make it worse. So keep in mind, we don't make it rain albuterol in the back of the ambulance, right? This is for patients who have wheezing, obstructive pulmonary pathology. So again, emphysema, asthma, bronchitis, bronchiectasis, right? Things like that, obstructive pathology where we hear wheezing. Wheezing will be in the vignette. They won't tell you wheezing sometimes. They'll say high-pitched expiratory noises are auscultated on exam to all lung fields, right? That is the code word for that's wheezing. So you need to treat that with albuterol. But what you don't do is when you hear patient has inspiratory stridor and a Silbart cough, the answer is not albuterol. It is the wrong answer. Okay. So respiratory medications, the most common one is going to be albuterol or derivatives of albuterol. On the exam, they're not going to give you another exam. They're going to say albuterol. So I want you to know short-acting beta agonist, specifically beta 2 agonist equals always albuterol. It's albuterol, okay? The trade name ProAir or Ventolin. So basically, the bronchoconstriction can be reversed with a bronchodilator. Wow. Common side effects, again, nervousness, anxiety, and tremors, and tachycardia. It will cause tachycardia. Okay. So they get real anxious and tremory with this medication. It's not benign like everyone thinks. Benign as in it doesn't have side effects. It does have side effects. So we can aerosolize this. This is done through a nebulizer. It looks like this. And how we do that is at 6 liters per minute, at least, usually more. And so what happens is air hooked up to our oxygen tank over here, right? It goes up through this, and there's medicine sitting in this cavity. It's around 3 liters. The albuterol nebulized dose is 2.5 milligrams and 3 milliliters, okay? And you pour that in there, and air will go through there, and it makes a fine mist. You put the patient's mouth on here, and then you'll instruct them to breathe in and dose it that way. Now, this is one of those where you want to explain to the patient, this is nebulized medication. It's going to help you breathe. I want you to take a breath in and try to work on focusing that medicine nice deep down into your lungs, because if they're hyperventilating, it will just stay in their mouth and trachea, and it's not very effective. Okay. Now, this is something called an MDI or a meter dose inhaler. You've seen these, right, in the school nurse's office. And so basically this is a metered dose, right? So every time they squeeze, you get a certain amount of albuterol shot through in a fine powder or mist. And so this is called a spacer or an apparatus. And so what happens is kids, okay, so for an adult, right, you can put this directly on your lips, right, and you're going to tell the patient to shake it, and they're going to put it on their lips, an adult, and they're going to tell them to simultaneously press and inhale in with a deep breath to try to force that medicine down into their lower airways. And so for an adult, we have that coordination to do so, but for a child, they do not. So you have to put it in a spacer to where it shoots the medicine in this spacer, right there, and then they'll put their mouth here and they'll take several deep breaths in to try to get all the medicine out of the spacer. Okay. So that's kind of what they, ensure the mist enters the lungs, have the patient inhale deeply and hold their breath. That way it stays down there as long as possible. This can be difficult when someone's short of breath, though. Keep the canister and spacer clean. Have the patient rinse the mouth after using. This becomes particularly important when there's a steroid mixed in there, like fluticasone, because if you leave that, first off, the medicine's kind of bitter tasting by design. But if you leave that steroid in the mouth, you can get a fungal infection called thrush, candidiasis. Okay, even normal, like a non-immunocompromised patients, they get thrush sometimes from using these medications and not rinsing their mouth. So the contraindications. So contraindications is reasons why we don't give a medication. The patient is unable to help coordinate the inhalation. The MDI, the meter dose inhaler, is not prescribed for this patient, or you don't have a medical order to do that, or there's no permission to do it from the medical control or protocol. The patient has already met the maximum prescribed dose. Usually that's 3. The medication is expired. So again, we check if the medication is expired, or if they're allergic to the medication, or if there's other contraindications specific to the administration. Okay. I'll tell you as a general rule, if someone's extremely tachycardic, you need to be careful giving beta-2 agonists like albuterol. You need to think twice. So the dry powder inhalers, again, these are the ones that are mixed with steroids typically. Geez, I can't think of the trade name of it. Anyways, there's a trade name of it. I can't think. It's not Flow Air. Maybe it's Flow Air. I don't remember. There's a trade name of them. Trulicid? Nah, I can't think of the trade name. Anyways, these are used typically with steroids and they're once daily, usually in the morning. Okay. Consider the fluid balance. We're going to skip that because we don't give IVs as EMTs. So you're going to support or assist the ventilation. So if the patient, this does happen, if the patient becomes fatigued and breathing, you might need to be supporting them more aggressively. So if the patient becomes in respiratory failure, you might have to use a BVM and breathe for them. Like that does happen. Okay. Some patient may simply require BVM for a short period of time to try to buy them some time and give them some rest time to where you're doing the ventilation for them. Okay. And gastric distension and vomiting can occur from overaggression or overaggressive ventilation. So if you ventilate too much, too fast, too aggressively, air will not be going in the lungs. It'll be going in their esophagus and into their stomach, and they're going to passively regurgitate. They're going to vomit, okay? So you got to be careful. There's a proper way to use that. We're going to cover that very extensively in lab. This is the single most difficult piece of equipment on an ambulance. It doesn't matter if you're a paramedic, physician, or doctor, or an EMT, or a nurse. This is very difficult to use properly. So we're going to cover how to use it properly a lot, and you're going to be very good at using this. This saves lives if you know how to use that, and it's very difficult to use properly. Okay, CPAP. We're going to kind of go into this because it's showing up, and it's becoming an EMT skill, especially in Texas. So CPAP stands for continuous positive airway pressure. So really think about that. We're continuously delivering a positive pressure to the airways, okay? And people typically sleep with this. So if you've ever seen someone that sleeps with a mask, it's called CPAP. And so we use this to treat obstructive sleep apnea. This is where people start snoring and stop breathing in their sleep because of obstruction, typically their tongue. And we can also use it to treat respiratory failure and heart failure and all these other things. And so many people sleep with CPAP. So a favorite question I'll ask is, do you sleep with a mask? And if they say yes, it's CPAP. And so that's like, oh, great. So they're used to this, okay? So how this works is you're going to be administered, so you hook this up to the oxygen bottle, right? And it's going to be delivering a constant amount of oxygen to their lungs in a constant pressure. And this pressure happens to be measured in centimeters of water, this weird measurement. And in this case, let's just make up a number, a common place to start, somewhere between 5 to 10 centimeters of H2O, right? And so what happens is there's this mask, I don't have one with me here, that goes on the patient's face. And it has these straps that'll mask it to the face and a little apparatus that actually looks like this that will be forcing air into the patient's face, and it creates a seal. And so you're forcing air down into the alveoli. So really think about this. If you start forcing air down into the lower airways, it opens up all those alveoli that may not be fully open, that may have a little bit of edema, pulmonary edema, that may have a little bit of rhonchi, a little bit of mucus and pus inside there. And so this becomes really useful clinically. So we use this a lot on the ambulance. And so you uh, we use this for short, like extreme shortness of breath, and it's very, very effective. Now, it has limitations and there's contraindications to this, but what I want you to realize is CPAP, continuous positive airway pressure, the benefit of it is it opens up the airways and it keeps them open. That's the really important part, okay? And so the success of CPAP is inversely related to the patient's respiratory rate. So if the patient starts breathing really fast, this therapy is probably going to fail. It's not going to work really well. So if they're breathing 40, 50 times a minute, it's not going to work. This won't work. Okay, so you may have to pull it off. But if they're breathing like, normal 12, 16, 20 times a minute, it works pretty well. And so there's clinical judgment of when you put this on and when you take it off. And I'm not going to teach you that today. It's probably more of like a lab scenario question. But CPAP keeps the airways open. That's what it does. And so it causes a pressure ventilation in the chest, which allows, oh, sorry. Let me show you, I jumped ahead. There's this thing called bilevel. So real quick, CPAP is a constant pressure. And let's just say we set it at 10 centimeters of water. Well, there's this thing called bilevel, and the trade name is called BiPAP, that looks like this. So it goes like this. And so this might be 10 centimeters of water, and this will be 5. And so as you can imagine, if you're breathing out against 5 centimeters of water instead of 10, it's a lot more comfortable for the patient. So BiPAP is more comfortable. So if you're asked what's the difference between BiPAP and BiPAP and CPAP, what's the benefit of BiPAP or bilevel positive airway pressure? It's because BiPAP is more comfortable. Okay, that's really the difference. Okay. But BiPAP's more expensive and it's more complicated. The hospital district does carry BiPAP, by the way. It's awesome. It's pretty new development, actually, for EMS providers to be carrying BiPAP. It's fairly sophisticated because you have to think about it. You have to have machinery that can realize when the patient's breathing in and out. That's fairly complicated to do. So upper and lower airway diseases. Yeah, the patient will present with severe respiratory distress. They could have dyspnea, cough, or nocturnal dyspnea. Nocturnal means shortness of breath. Nocturnal dyspnea means shortness of breath at night. Okay, and wheezing can be present. What's the treatment for wheezing? Very good. Albuterol. It's a beta 2 agonist. Okay. Place the patient in a position of comfort. That's almost always going to be upright. Monitor the airway, apply high flow, assist ventilations if needed, transport and contact medical control. Now, the treatment for pulmonary edema, now we're going to start jumping in what's the treatment for each of these. It's usually associated with cardiac disease like acute coronary syndrome or heart attack or long-standing hypertension, hypertrophy, something like that, or direct lung damage. Pulmonary edema can be caused from pneumonia or infection or something like that. So you're going to want to administer oxygen, and sometimes you might need to suction the airway. I will let you know that if you see on an exam, they say the patient is coughing up a frothy, pink frothy sputum. That means pulmonary edema. I'll say that again. I'll write it down for you. Pink frothy sputum equals pulmonary edema. This is very extreme of pulmonary edema. But you'll see this on exams and in real life. You will see this. They'll be coughing up this pink frothy sputum. That means there's blood mixed with their pulmonary edema. And they're coughing it up because they're literally drowning. They're coughing it up. Like it has reached that level. So that means pulmonary edema. So I'll say that again. Pink frothy sputum is code word for pulmonary edema. Okay. Now you're going to provide oxygen for these patients. Sit them upright. Sometimes you might use CPAP. This is very effective for the treatment of pulmonary edema. And that is supportive care. Rapid transport to a hospital. You might have to suction them. Okay. Aspiration. So this is inhalation other than gases, right? So you can aspirate chocolate milk, water, grapes, food, vomit. Okay. It's very, very deadly when this happens because you got to think about it. What do you think some pineapple juice to the lungs is going to do, right? Or some chocolate milk to the lungs? It's going to cause infection. It's going to cause inflammatory response. It's going to cause scarring. And so they're probably going to get a wicked pneumonia, especially vomit. Oh my God, imagine vomit to the lung. This is very common. Vomit to the lung. It's very, very, very hard to treat. Very deadly. And so this is why we don't want to overventilate people and pump with the BVM and end up pumping gas into their belly. So if you're too aggressive with this machine with the BVM, you'll pump gas into their esophagus and it'll go into their stomach. Their stomach will stretch and eventually all their food is going to come up and then it's going to go into their trachea and then they're going to have aspiration pneumonia. Okay. So you want to aggressively monitor the patient's ability to protect their airway. Aggressively treat aspiration with suction and always control the airway and be prepared to control the airway if the previous steps failed. So just be aware. If I have a sick patient, I have the suction yonker up underneath their head. So I'm ready to suction them if they're gonna vomit. Like I'm already ready. I already have it turned on. The suction's turned on off the wall. I have it out of the wrapper and it's stuck up underneath their pillow. Okay, or up underneath the stretcher, to where all I have to do is grab it and shove it in their mouth and nose and go to town. COPD, so patients, they're obviously going to shortness of breath. So a lot of times we'll assist them with a prescribed inhaler if there is one. In Texas, a lot of times we'll just go ahead and give it nebulized albuterol, even at the EMT level. You'll have a protocol to do that. And then sometimes they'll do this thing called auto peeping. Again, that's the pursed lip, where they'll be doing that themselves. Okay, they already figured out if they do that, they can breathe better. Now, asthma, there's this triangle, this triad to this. The one that we most aggressively treat is through bronchodilators, which to treat the bronchospasm that's taking place. Okay, but sometimes we'll treat airway edema with corticosteroids. We don't do that at the EMT level, but we do that at the paramedic and physician level, of course. And then sometimes we'll treat the mucus production which is odd, with water like hypertonic saline and expectorants. Okay, so you don't use these to pre-hospital a lot, but we certainly use albuterol to treat this. Okay, so again, you want to look for subcostal retractions. These are very telling, especially in children. You will see this. There will be a video below in the link of these that show that. Okay, so be prepared to suction and administer oxygen. For asthma, you're going to use slow, gentle breaths when ventilating. Of course, you don't want to overventilate these patients and pump air into their guts. Emergency care. I don't like this line. Emergency care of the child is the same as an adult. I don't know about that, JB Learning. But we need to talk about this thing called status asthmaticus, right? This is asthma that's not relieved with therapy. Okay, and this happens a lot, especially in children. And so status asthmaticus is when you keep giving albuterol and you keep treating it like acutely, like nebulizer after nebulizer after nebulizer, like one after another, continuous nebulizers, and they're still in extremis. Okay, so they're still having a really difficult time breathing. That's called status asthmaticus, and it's obviously an emergency. Okay, they need to go to the hospital quickly for additional therapy like corticosteroids and magnesium, like a magnesium drip. Now, aggressive airway management, sometimes you have to get aggressive with these patients, but I will say, don't jump the gun. You'd be surprised what some good nebulized albuterol and some oxygen will do for someone, and some reassurance, sitting them upright, coaching them on their breathing, but you need to transport these patients rapidly, of course. Okay. Now, anaphylaxis. You want to remove the offending agent. So if they're covered in ants, get the ants off them. If there's a stinger in them, remember we use a credit card to get the stinger out, okay? To wipe it off, kind of scrape it off. Now, maintain the airway. You have to realize the chance of their airway swelling shut is very great. There's probably going to happen if you don't treat this or if it's late stage. Their their mouth will completely swell shut, so you cannot get air in out. They're going to die when that happens. At the EMT level, at the paramedic level, you have to cut their throat. Very big deal when that happens. Administer supplemental oxygen. You're going to assist their breathing as needed. You're going to manage the ABCs. You're going to provide airway and ventilatory support. And you're also going to go ahead and administer albuterol. At the paramedic level, we administer diphenhydramine, which is Benadryl, antihistamine, right? Because histamine is causing all these nonsense problems. And epinephrine. So this is a trainer one that I have. This is by AviQ. And basically, you pull it out. This one actually talks to you. You pull this little red thing off. This goes on the side of the thigh, the lateral thigh. And make sure this is the trainer. You push this in there and you hold it for a few seconds. 10 seconds is usually how long, like the EpiPen. So she starts talking a lot. But this is just one example of them. But this is an EpiPen. What's the dose of epinephrine? I'm glad you asked. For an adult, 0.3 milligrams sub-Q. Okay? That's the epinephrine dose. Now, pleural effusion, the treatment's removal of the fluid outside of lungs, but you're not doing that in an ambulance, okay? So that's not even really done in the ER very often. It's done in the ICU typically. So it's kind of a big deal to do that. So I don't know why they're so big on telling you to remove the fluid. You can't, okay? Paramedics can't. So provide oxygen and routine support. Again, these patients are going to sit up. Now, pulmonary embolism, I'd say the greatest thing is you have to recognize it's a pulmonary embolism and transport them. But manage the airway. You have to provide high flow oxygen. Remember, this is a VQ mismatch where there's a perfusion issue, not necessarily a ventilation issue. So oxygen does have limited therapy, but it is worth trying because they could end up dying. You probably they can code very quickly. I've had this happen where you get there and they're just turning blue while you're talking, like trying to get him on the stretcher, and the guy died like that, went straight into a systole and didn't get him back. Okay, so they're going to go into cardiac arrest eventually if it's untreated, or if it's a really big saddle thrombus, where it blocks the left and the right side of the pulmonary artery. Hyperventilation. So again, common reassurance. You can give oxygen, even though they're hyperventilating. I'll say this again. You can give oxygen to them, okay? You're going to provide psychological support. This is not always, but almost always going to be anxiety driven. So we just want to provide common reassurance. Hey, it's okay. I'm here with you. We're going to take good care of you. How can I help you? This isn't necessarily time to do Dr. Phil therapy on them, but I'm trying to reassure them. Remember, don't tell the patient, just calm down, slow your breathing down, right? That doesn't work, okay? It just pisses them off. So, obstruction of the upper airway. So, if we can, which you got to be careful. You would want to try to remove it based on the BLS guidelines, right? So you might try to tilt their head, or we don't do blind finger sweeps anymore because we can push the object further down if it's in the mouth. But a really good way to do this is suction, or just turning their head or turning them to their side and seeing if it'll fall out. Okay. If the patient can't talk or breathe, you might have to do the Heimlich. It kind of depends on the obstruction, but the Heimlich and then really kind of tilting the head to the side or aggressive suctioning are probably your best bets. Supplemental oxygen. Now, if it's completely obstructed, they're going to go into cardiac arrest. So be prepared just to start CPR. Environmental industrial exposure. So, of course, remove the patient from the offending area. Activate the hazmat team. Remember, your safety's first. So remember, when you take this exam, you are not firefighter Randy, right? You are EMT student Hunter, and you cannot be doing firefighter stuff on the National Registry exam. It will cause you to get problems wrong, and they love it. They love it. They love duping you. They love making these firefighters pick the firefighter answer instead of the EMT answer. You are an EMT only. Delete your firefighter knowledge when taking these tests, okay? You're going to have to decon them, okay? Provide oxygen, or you might have to assist their ventilations if necessary. If the upper airway is compromised, you might have to aggressively manage their airway, okay? Be prepared for swelling. When we inhale irritants like chlorine or whatever gas, dust, you can get really aggressive swelling. So you might have the airway might close off. Bronchiolitis. Who gets bronchiolitis? It's children, typically less than 5 for sure. And this is from a virus known as RSV, Respiratory Syncytial Virus. And it produces lots and lots of mucus. And how we treat this is with aggressive suctioning. And sometimes, it's very rare, we might have to assist with a BVM. We do give them oxygen, typically through a nasal cannula or through blow-by. Remember, blow-by is where we just provide a little bit of oxygen close to their face. What I like to do is have the parent hold the mask and just kind of hold it next to the child's face, just blowing oxygen near them. That's called blow-by. That is an acceptable therapeutic intervention. Now, the respiratory syncytial virus, what works really well for these patients is humidified air. So you could take normal saline, right, and put it in that little nebulizer thing that we typically give albuterol through at 6 liters a minute or more. And you can just let that nebulized air blow on their face, and it is very effective at treating them, okay? What happens is, especially if you use hypertonic saline, like 3% saline, is it kind of moistens up the mucus to where they can kind of cough it up and clear the mucus a little easier. So it is very effective. Don't doubt the effectiveness of just humidified oxygen. Very effective. Croup, remember this is a virus, the paramyxovirus. So basically, what happens is you get steeple sign. So remember, this is the normal trachea. This is the trachea with croup. So it gets swollen. So as air tries to go down, it creates a pattern of upper. When they inspire, it will create a high-pitched sound known as stridor. Okay, remember stridor equals upper airway. And so this is in the trachea or in the larynx. And so basically, also, we treat this with humidified oxygen. In fact, sometimes you'll see on exams, they'll say that the patient sounds better after a shower, or the patient sounded better after going into a steamy room after a shower. Why is that? Because the steamy room has humidified oxygen, and that humidified air makes it sound better. Doesn't necessarily make them better, but it makes them sound better. So that's the treatment for this. So you don't want to agitate these patients. You could try some blow-by with humidified oxygen. It's very effective at making it. It doesn't make them better, but it makes them sound better. Now, sometimes you don't see this really at the EMT level, but I'll talk about it. You could nebulize epinephrine. It's called racemic epinephrine or nebulized epinephrine. And it's very effective in the treatment of croup. What happens is nebulized epinephrine will reduce the swelling right here in the trachea. Very effective. But this isn't as common practice, especially at the EMT level. Epiglottitis, remember this is a bacterial infection. The patient will be leaning forward, fever, sore throat, and drooling. The patient will be drooling because it hurts to swallow. The epiglottis is the little food flap that sits over the trachea. Don't put anything in the patient's mouth. Don't piss them off. Don't make them angry. Don't make them cry. Take them to the hospital. It's a life-threatening medical emergency. Do not irritate them. If they start crying, they're going to get worse. And also don't freak out. Chaos is contagious. So just stay calm, take them to the hospital. Also, this is contagious. Epiglottitis is contagious, so you need to report your exposure. There is a rifampin. There is an antibiotic sometimes that's administered to close contacts. Typically, if you're wearing a mask on an ambulance, you don't need it. But like close contacts, like the parents, especially if they're not vaccinated, they'll get an antibiotic. So this is reportable. Okay. Now, pneumonia, we talked about this. It's almost always a bacterial infection. What lung sounds does it present with? Rhonchi, and occasionally it will also have rales or wheezing, but almost always you'll hear rhonchi. Where does this typically occur? Good question. It's typically in the bases. Doesn't have to be. Could also be in the middle lobe or in the upper lobe, but it's typically in the bases. Typically, it's unilateral as well. So typically you'll hear rhonchi on one side. Okay? So you're going to, it's just supportive care. Pertussis, also known as whooping cough, also highly contagious. There's a vaccine for this. So if you're vaccinated, you don't have a lot to worry about. It's a toxin. So basically this bacteria will produce a toxin that will stimulate the child to cough, 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 and will cough so much that when they finally take a breath in, they'll make a whooping sound. So that's where the name whooping cough comes from, but the medical word for this is pertussis. So basically how this will present is they'll cough, cough, cough. There's two other ways this will present though. Occasionally they'll have hypoglycemia and what's called post-tussive emesis. So they will cough so much they will vomit. You will actually see that. That is a real thing. That you can even see this with RSV and asthma. They will cough so much that they will vomit. Okay? It's called post-tussive emesis. Tussive means to cough. So after they cough, they vomit. Post-tussive emesis. Airway obstruction in the child, clear the airway. Who knew, right? Heimlich, turn them over, provide oxygen transport. Heart failure, CPAP is probably the hallmark of treatment with this. Supportive care. Remember, albuterol can make heart failure related pulmonary edema worse by messing up the heart. You make the heart beat faster. So be careful with that. Excuse me, not every patient gets albuterol. Tracheostomy dysfunction, I can't tell you enough. The family tend to be experts on this, not you. You're getting one slide in EMT school on this. They are experts. So allow them to troubleshoot you. So when I've gotten these calls before, it's like the tube has fallen out and they don't have a replacement. So we need to take them to the hospital so they can replace the tube. Or the ventilator's failed and they know it's failed. So they will have one of these BVMs at home prescribed to them and they're already have it hooked up and using it. So we just need to continue using the BVM or hook them up to our ventilator and take them to the hospital. Or their suction machine broke or whatever. So just know that the family tends to be experts on this, so lean on them. I will say, sometimes you can get a mucus plug in this tracheostomy tube that sits down here. They can't cough very effectively or clear this themselves, so you have to suction these patients pretty aggressively, and sometimes that can become plugged up, and that's called a mucus plug. So you have to clear that obstruction. Sometimes it'll be so thick and mucousy, you have to put a little saline or water, sterile water, down there to loosen it up and then try to suction it out. I've had that happen before. Okay, but you got to clear the airway. This doesn't just happen in kids, though. It happens in geriatrics and adults, too. Now, these last very few slides are on COVID-19. Yes, COVID-19 is on the National Registry. Okay, so this shouldn't be a surprise to you. We probably have all had COVID-19. I may or may not have had COVID-19 3 weeks ago. Shout out. So, yeah, it happens. Now, epidemic. Okay, so they could just ask you, what's the difference between an epidemic and a pandemic? Okay, it's annoying, but this is epidemiology, okay? The study of disease. So an epidemic occurs when new cases of a disease occur in a human population that is substantially exceed what is expected based on the recent experience, right? And so it's basically an epidemic's an outbreak, okay? And a pan means all, by the way. Pandemic is on a global scale, okay? So we can have an epidemic outbreak of West Nile in Dallas, right? That happens every now and then. It's an epidemic, okay? But if all of the world suddenly got West Nile, that's a pandemic. And that's what happened with COVID, right? It started off as an epidemic in Wuhan, China, right? Not my opinion. And then it spread internationally, especially with international travel as it is today. This happens really quickly. And so, especially with viruses, even parasites. And so then it spread across international borders really quickly, and that's how it became a global scale, and that becomes a pandemic. So to tell the difference between the two, if you realize that the word pan means all, right? It's a demic of all, right? That it's a global scale, it's a pandemic. That's the difference between the two. So, there's many potentially serious diseases can be passed by the respiratory route. Influenza, RSV, enterovirus, norovirus, COVID, obviously. It happens. So wear your PPE. Frequent hand washing, guys. I wash my hands after every call, and it is odd to me that is not the common practice, and it's not. But wash your hands often. Like wash. It's. I mean, yeah, you wear gloves, but wash your hands. Like I'll even wash my hands. Put the monitor up and clean up the ambulance. Go back into the hospital and wash my hands. Wash your hands, or at least alcohol them. Okay. So, I'm not going to get into vaccines, but I think vaccines are valuable, whether the COVID, I won't talk about that. But anyways, vaccines are good for the most part. They're good, especially the known ones, right? Like Hep C, Tdap, all those, meningitis. Wear a HEPA filter during aerosol generating procedures. What does that mean? So you might need to wear more than like a surgical mask or a regular N95, ideally, or at least a well-fitting N95 or a P100 mask when you're putting someone on CPAP or you're nebulizing air like a albuterol or something like that. It puts the virus into those particles, those moisture particles, and it allows them to travel a lot more efficiently. I'm going to go through this quickly because I think we know about COVID. We've all been here, right? At least I have 4 times that I know of. So let me say this, though. Coronavirus is not new, okay? In fact, there's seasonal coronavirus, seasonal cold. We've had this. But the SARS-CoV-2, like the COVID-19, right? The SARS version of it is novel. That is new. We had a little outbreak in like a 0204, but the current version of COVID that we know it, coronavirus, there's multiple strands of it, obviously, by now. But realize that is different from seasonal coronavirus that's been around. Now, it spreads through respiratory droplets. We know this. The common ones are fever or chills, cough, sore throat, and loss of taste or smell. Okay? It becomes an emergency when there's dyspnea, chest pain, confusion, cyanosis, or the inability to wake up someone, lethargy, altered mental status, right? Older adults and those with pre-existing medical conditions, of course they're going to be sicker. I have a saying, the sick get sick, okay? So if you're old and sick, you're going to get sick when you get COVID. Now, follow these guidelines to avoid COVID-19 contamination. Wash your hands, wear PPE, avoid touching your eyes, nose, and mouth. That's the problem that I have with making people wear masks, is they constantly readjust their mouth, so they're touching their nose and their mouth like all the time. They're just contaminating themselves. Cover your coughs for sneeze. Stay home when you're sick. Wear a mask that covers your mouth and nose when out in public. Again, guys, not my opinion. It's in your slides. So maintain 6 feet. Get a flu shot. Get a COVID shot if you want. It does show to reduce the mortality and hospitalization rate. That's up. I mean, it doesn't really reduce infection rate as significant as we would hope, but that's up to you. Clean your electronic devices. Clean your ambulance. Follow the manufacturer instructions for disinfection. So wear an N95 or higher level respiratory mask when taking care of these patients. Wear eye protection. It's really not spread by droplet to the eyes, but here they are recommending that. Wear disposable patient examination gloves and wear a disposable gown. The reason that you want to wear a gown and mask, or really a gown, and even the goggles, is because it can sit on your skin or your regular uniform and cause infection by fomites by touch. Okay. Proper donning and doffing, we'll cover that in the lab with how to do that. This is the last slide. So um, generally you want to if someone we haul, so we take these patients to the hospital. But COVID-19 in generality isn't that lethal anymore. I mean, the weak have died already, right? The Darwinism of this, but we don't see as many hospitalizations now that we know a lot more about the disease. And there are treatments like pelaximab, or not pelaximab. I can't think of the name. Anyways, there's a medication out there that's fairly effective at treating COVID now. An antiviral. It starts with a P. Anyways, just treat the patients. Okay, this is contagious. You do get this. I got it recently, allegedly, maybe. So just know it happens. It's out there. Protect yourself. And with that, that is the respiratory chapter. I appreciate y'all's time. And yeah, bye.